And then there's also, oh, this was when I was going to do a Q&A. We're going to skip this. Ignore that. Okay. So my name is Elizabeth Brewer. I am facilitating the WebEx portion today. I'm the Director of Research and Care Transformation at Kootenai Health and one of the co-chairs of the Caregiver Wellbeing Committee. And then my co-host is Dr. Emily Peterson, who can introduce herself, but she's going to take over now.
Hi, everybody. As Elizabeth said, I'm Dr. Emily Peterson. I'm a nephrologist here at Kootenai and co-chair with Elizabeth of the Caregiver Wellbeing Committee. And we are very excited to bring you this topic today. It's on weight bias, particularly in medicine. I think this is a really interesting topic and something that is kind of a newer and emerging area of research and kind of new thoughts as far as how we talk about weight and people living in larger bodies and how we manage that in our clinics and in medicine. And so we have some very distinguished speakers today. I'm very excited to introduce you to Dr. Michelle Proper. She's a radiation oncologist practicing at Community Medical Center in Missoula, Montana. She did undergrad in genetics from University of Wisconsin in Madison and attended the University of Illinois at Chicago for medical school and University of Colorado for radiation oncology. She's an assistant professor at Virginia Commonwealth and joined Billings Clinic in 2013. She's been in Missoula since 2014. She takes an active interest in advancing cancer care through research and is the principal investigator for the Montana Cancer Consortium, which is an NCI community oncology research program that brings national clinical trials to patients in the community. And Kootenai Health is an active enrolling member of this consortium, which is how we became acquainted with Dr. Proper. She gives the Montana Cancer Consortium national representation by sitting on the NRG Data Monitoring Committee with a focus on patient safety and the NCI Gynecologic Steering Committee as the community oncology representative. As I said, very distinguished panelists today. So thank you so much for joining us, Dr. Proper, and I will turn it over to you.
Thank you for having me. I'm excited to talk today and also to listen to the other panelists as well. And sorry, just to remind myself, do you have my slides?
I sure do. You just tell me when.
Okay, so today we're going to talk about obesity and cancer. And next slide. I have no disclosures. Nobody is paying me to talk about this today. So today I'd like to define some obesity-associated cancers, talk just briefly about the mechanisms that contribute to cancer, and then how does obesity contribute to side effects of treatment as well as outcomes in treatment. Next slide. So which cancers have been associated with obesity? Next slide. So, well, first off, obesity, what is the definition of obesity? And the WHO defines it as abnormal or excessive fat accumulation that presents a risk to health. And so there are various ways to define this. The easiest way is body mass index, which just takes your height and weight. And essentially over 30 is considered the obese category. And BMI is supposed to be kind of an indirect measurement of body fat percentage. So a BMI over 30 would be about 30% body fat. Next slide. But as you can see, this is Dwayne "The Rock" Johnson, and he was filming for a movie here, and he's highly muscled, and his BMI in this picture was 34. And if you want to advance it, the average American who has a BMI of 34 probably looks more like this. So BMI is not perfect, but it is a fairly quick and easy and cheap measurement that is that we can help us anyways in terms of studying this problem. Next slide. So the other kind of definitions go again by body fat percentage or abdominal circumference. And then important in cancer is actually sarcopenia, so loss of muscular function and skeletal muscle. Next slide. So the IARC, the International Association for Research on Cancer, defines 13 obesity-associated cancers. On the right-hand side here, we have the kind of the GI-related cancers: colorectal, gallbladder, liver, hepatobiliary, esophageal, pancreatic, and gastric cancer. And then on the left side, female breast, uterine, ovary, kidney, thyroid, and melanoma. On the infographic here, meningiomas are also associated with obesity. However, that is not technically a cancer, it is a benign tumor, but that is also associated with obesity. Next slide. There are other cancers that are implicated with being an obesity-associated cancer. So male breast cancer, aggressive prostate cancer, bladder cancer, sarcomas, melanomas, and leukemias. Unfortunately, with leukemias, this is actually a problem in children as well. So we know that overweight children are at an increased risk of not only childhood cancers in general, but also with leukemia. And then interestingly, there's also some data that says that children born to moms with a BMI over 40 at a pre-pregnancy weight have about a 60% higher fold chance of being diagnosed with leukemia as a child. Other cancers: laryngeal cancer, CNS tumors, small intestine, and cervix cancer. And in cervical cancer, there's kind of a question of whether this is a problem with detection. And if you advance it, this graph here, the yellow shows essentially precancerous lesions. And this was a study out of Kaiser, and it was over 1 million pap smears. And in obese women, there's a lower incidence of precancerous lesions. The blue there is actually the incidence of cancer. So there's a higher incidence of cancer, of cervical cancer, in overweight patients. And so when they thought initially it might have been a detection issue, and when they limited it to colposcopies, it still held up. And so the question is, maybe is this a detection issue, or is it actually that these cancers are advancing from a precancer state into cancer quicker than in normal weight patients? Next slide. So we are in the midst of an obesity epidemic. So about 30,000 men and 70,000 women will be affected or will develop a cancer thought to be related to obesity. And the CDC estimates that about 40% of all cancers are currently being caused by overweight and obesity. And by 2040, it's thought that obesity will overtake smoking as the #1 risk factor for cancer. The other unfortunate issue is that there is a shift in the number of cancers to younger patients, and most particularly in younger Hispanic women. So some of the cancers that we are seeing that are obesity associated do tend to occur in younger patients. And again, unfortunately, this is disproportionately affecting younger women. Next slide. So how does obesity increase the risk of cancer? And I'm just going to take a brief second here. And there's 3 real pathways. One is the endocrine-related pathway, the second being insulin and the metabolic pathway, and then the third being inflammation or the tumor microenvironment. Next slide. And I'm not going to spend too much time, but suffice it to say that they are kind of all interconnected, and it's also very complicated. So next slide. In terms of endocrine, what we know is that we used to think of fat or adipocytes as just kind of a storage, but what we do know is that it's actually an active organ, and part of that active organ is converting estrogen into, converting testosterone into estrogen, and this happens both in men and women. The other interesting thing is that adipokines that are released from fat cells, mainly leptin, decrease sex hormone binding globulin, and that allows for more free estrogen in the body. Next slide. Why is this a problem? Well, estrogen is actually a mitogen and a mutagen. So it is a mitogen in that it is a transcription factor and tells the cell to go through mitosis and to grow. It is a mutagen in that its breakdown products actually create DNA damage, and that can create DNA instability. So when we have excess estrogen in our body, it can be a problem. Now, there's an estrogen receptor that is this transcription factor, and there's an alpha and a beta form. The alpha is found in endometrial cells, breast, ovary, hypothalamus, and the efferent ducts of the testicle. And the beta is found throughout the body, lung, bone, kidney, heart, ovary, prostate, and endothelial cells. And again, this is both in men and women. Next slide. Just a quick slide on insulin. Insulin is around when we have, sugar and there's a good growing environment. It tells the body, to keep growing. And so part of that downstream effect is that it increases the chance of cancer cells it increases cancer cells protein synthesis, angiogenesis, and its ability to get blood vessels to those cancer cells, as well as migration and survival. Next slide. Inflammation is a hallmark of cancer, and we know that adipose tissue can secrete inflammatory cytokines. Some of the fat also is a deposition of stem cells, which is good for healing, but sometimes those stem cells can be recruited to support tumor growth, which is not so good. Some of the adipokines, interleukin-6 and TNF-alpha, suppress insulin signaling and contribute to insulin resistance, which can make the problem worse. And then specifically in the omentum in the gut, in the abdomen with ovarian cancer, we know that interleukin-6 and interleukin-8 can actually promote homing and migration of ovarian cancer cells into the omentum. And then once those cancer cells are in the omentum, because it is fat, there's lipolysis going on, and there are free fatty acids available to these cancer cells to help them grow. So it's been implicated as an energy source. Next slide. And I'm going to take just a minute to talk about endometrial cancer and prostate cancer. Endometrial cancer, more than any other cancer, is highly correlated with obesity. And in the kind of the class 3 patients, they are 7 times more likely to develop uterine cancer. And 60% of uterine cancers are thought to be related to excess weight. Now, oral contraceptives are protective against uterine cancer, and even copper IUDs, interestingly. But the real downside is that obesity increases the risk for more aggressive histologies. Next slide. So the incidence continues to rise for endometrial cancer, and it's rising about 1% per year. And again, that rise is coming in these poor histologies. When we correct for hysterectomies, knowing that about 25% of women have had hysterectomies for other indications. So if we correct for those patients who have already had their uterus out, uterine cancer becomes the second most common type of cancer diagnosed behind breast cancer. Next slide, or advance it. In this graph here, the red line is African Americans, and so this is actually disproportionately affecting African Americans. So this is the incidence of cancer. And then if you can advance it. And then one, yeah. So unfortunately, when we look here, Black women, when we even localized or distant, they are not doing as well as Caucasians and Hispanics. And part of that is because that they have these worse histologies. So again, it's really unfortunate, kind of compounds some of the socioeconomic factors with them as well. Next slide. Prostate cancer. So prostate cancer is not obesity associated and or defined by the IARC, but because it slightly reduces the risk of non-aggressive prostate cancers, such as Gleason 6. But some of these non-aggressive prostate cancers, we actually advocate for active surveillance in men. And obesity does increase the risk of more aggressive disease. So the question, again, kind of similar to cervical cancer, is it a detection issue? Studies suggest that prostates are larger in obese men, and so if we're doing a random biopsy, we may miss cancer more often. Digital rectal exam may be more difficult in obese men, although I would argue very few prostate cancers are diagnosed by rectal exam alone. And we do know that PSA values are lower in obese men. And so there is greater, is this a plasma dilution problem, or is it because of lower testosterone? Next slide. Now, if we go back to that, thinking about how fat cells convert testosterone into estrogen, obese men will have lower testosterone. Testosterone does not cause prostate cancer. It's kind of simplistic. We take advantage of that pathway in treating prostate cancer, but testosterone actually promotes normal prostate epithelial differentiation. And so low testosterone may actually affect tumor differentiation. So multiple studies have shown that patients developing cancer in the setting of low testosterone for various reasons typically have more advanced and more poorly differentiated tumors. Now, there's been 2 trials with prostate cancer prevention, one using finasteride, which is trying to decrease testosterone at the level of the prostate, and that did decrease prostate cancer, but it slightly increased the aggressive histologies. There was another study that was a randomized phase 2b study using toremifene, which is a selective estrogen receptor modulator similar to tamoxifen. And that actually decreased prostate cancer by almost 50%. Now, these patients had PIN, or prostatic intraepithelial neoplasia, so it's a precancerous. And so it did actually decrease the risk of all histologies, low grade and higher grade histologies. I don't know that it's gone on to any phase 3 or that people are using it, but that's actually some really good data out there. Next slide. So what about treatments? Next slide. We know that unfortunately obese patients who are getting surgery, they have higher risk of complications, so they'll have more pneumonias, thromboembolic events, specifically looking at mastectomies, they have more infections and wound dehiscence, and they'll lose implant reconstruction more often. Lymphedema is actually higher. The #1 risk factor for lymphedema and breast cancers is actually body weight, BMI. And then a second one is surgery, and then kind of a distant third is radiation. And then the other thing is in terms of the pelvis, men have a more narrow pelvis in general, so surgery can be more difficult. So we know that in rectal cancer, they have lower rates of local control. And in prostate cancer, they have higher rates of positive margins and higher rates of incontinence after surgery. Next slide. In terms of chemotherapy, this is based on body surface area. And initially, patients were reduced. Obese patients had dose reductions, but this led to poor overall survival. So now we do full doses. Unfortunately, those patients do have higher side effects. They will have more neuropathy and more cardiotoxicity. And in the fat-soluble chemotherapies, we may actually be under-treating them, even with the higher toxicity. Next slide. Radiation increases skin reaction or desquamation in obese patients where we're treating the breast or the pelvis. Radiation doesn't really like skin folds, and we know that obese and diabetic patients have higher risk of chest wall pain after mastectomy or radiation for early stage 1 cancers. Next slide. So this is a normal weight breast cancer patient. What I can say is that it's very homogeneous. It looks, there's nice sparing, that it's a good plan. If you can advance it. So for women who are pendulous, where their breasts kind of will drop down, we can separate the breast from the chest wall, and that decreases that risk of skin reaction. And if you advance it again, what that does, again, is it brings the breast down. It allows us to avoid the heart and lungs almost entirely. And so this is one way that we've tried to adapt our radiation therapy for larger breasted patients. If you can advance it. So in terms of outcomes, next slide. Unfortunately, obese patients in a lot of cancers, and when we kind of look at them all together, ultimately the risk of recurrence is anywhere from 1.5 to 1.8 times the risk of recurrence in cancer mortality. Next slide. So in breast cancer, there's a 35 to 40% increased risk of breast cancer recurrence. And unfortunately, even women who are gaining as little as about 10 pounds have worse outcomes. This is especially problematic because most women will gain weight with chemotherapy, and they typically are gaining fat and not muscle. And then there are multiple GI cancers that show worse prognosis: esophageal, gastric, pancreatic. And we talked about obese men with rectal cancer. Next slide. And then even in the non-obese associated cancers, patients have worse outcomes. So there's worse pathology, and we know that in oral tongue cancer, inflammation in that adipose tissue predicts for worse outcomes, and vulvar cancer patients that are obese tend to do worse. Next slide. So weight loss, is it important? And yes, before diagnosis, there's pretty good data that says that it decreases the risk of cancers, multiple cancers. The biggest one is endometrial cancer, and very little amounts of weight loss can decrease the risk of endometrial cancer. And then there is also data to suggest that if we lose weight, it decreases our risk of breast cancer as well. Next slide. Our best data, though, comes from the bariatric setting, where they have sustained pretty significant weight loss, and they have really high rate, much significantly lower rates of a cancer diagnosis in patients who are undergoing bariatric surgery. And some of the newer medicines nowadays, I think, in terms of weight loss, are rivaling bariatric surgery, and so hopefully we can get on top of this problem. Next slide. So after diagnosis, the best study actually was a low-fat study. It was started in the 1980s. So in terms of how to lose weight, there's no one way to lose weight, and that did actually show improved survival in those patients. Next slide. So this is the hard part, right? We have to approach this very cautiously with patients. Cancers will come back regardless of their size. And so we don't want patients to feel like their cancer came back because they couldn't lose weight. But we do know that trying to lose weight is beneficial. So I often start with talking about physical activity and getting that into a habit, and then talking about diet and maybe smaller portions, using a food scale, more fruits and vegetables. And again, no one particular diet, no keto, or just kind of trying to help patients and also make it sustainable for them. And I think that's onto my last slide here, is that obesity increases the risk of multiple cancers. Unfortunately, we have worse side effects with our treatments in obese patients. And then the last part is that unfortunately they also have worse prognosis. And so sometimes I think there is a fear of cancer or a reverence for cancer. And talking to people about this, this could be a motivator to help them start to be a little more physically active, or to take some of the smaller changes and try to lose weight. And that is my last slide.
Thank you so much, Dr. Proper. That was fascinating information and really helpful. And I think, this is just such a complex topic that I think you kind of alluded to it. Weight loss is not a simple thing. And we have two additional speakers who are going to talk to us a little bit about what it's like to, work with people who are living in larger bodies and are struggling with their weight. Next up, we have Megan next, right? Kimberly. Okay, sorry. We have Kimberly Young, who's a dietitian at Panhandle Health. She serves as the Health Service Division Administrator at Panhandle for the last couple of years. She graduated with her dietetics degree from the University of Idaho, served an internship at Deaconess, and has a master's degree in family and consumer sciences, where she studied dietitian involvement in teen health and well-being. And she's going to talk to us about youth and obesity. And we really appreciate having her here. So I'll turn it over to you. Thank you, Kimberly.
Okay, great. Thank you. So yes, good afternoon. And I want to thank all of you, the opportunity to speak with you about obesity and youth and inclusive care. So, I'm speaking about the youth based on our experience delivering overweight and obesity care to our youth population through our WIC program. So here at Panhandle Health District, we have our Women, Infants, and Children program, and then also our PLAY program, which is Parents Leading Active Youth. So I'm just going to speak to some experience there and how we approach the subject of obesity with our parents, caregivers, and youth. And next slide, please. Okay, so as was mentioned, obesity is very complex. It can stem from adverse childhood experiences, so using the ACE scores. And we do know that the higher scores provide higher risk for developing chronic disease. However, more research is needed. Is it because there's stress and trauma that they have endured? Is it emotional eating that is tied to that? Those are some of the things we can't really answer. We just know that the higher the ACE score, more likely the higher the risk of chronic disease development. So, of course, with that, there's so many factors that can contribute to obesity. So, of course, lifestyle, physical activity and nutrition. And of course, that's the first thing that we're going to approach because that is probably the most that we can control at the moment as far as talking about it. But again, there's the environment. Is it a built environment where they have access to green spaces or to parks, or do they have access to nutritious foods that are affordable? Also, genetics plays a role, and then food insecurity, which would probably play into that environment as well. So just having that empathy and understanding that knowing that there's multiple factors that could contribute to obesity or overweight is really important to understand. So if we just have that empathy and understanding moving forward, we want to avoid labeling terms. So instead of saying obese child, we often will use child with obesity or that's presenting with obesity or overweight. So using preferred language, so I'll dive deeper into that. Really we try to, of course, we all know that we need to take someone's weight. We need to, look at their BMI. There's different measurements that we do use. However, instead of focusing on those things with the clients and the parents or the youth, we will focus on goals that are on lifestyle interventions. So we want to really hone in on reducing those factors that would increase the risk for chronic disease. So we would really talk about, lifestyle changes that they can do, meet them where they're at. It's definitely a multifaceted approach. So looking at all those things that contribute to obesity and the complexity of it, kind of honing in when we have conversations, we like to kind of dive in deeper and talk about some of those underlying causes as well. That way, as we use motivational interviewing, this empowers the families and children to make choices on their own. We facilitate that so that they have that buy-in and they are making that choice because they want to make that choice. And so just for an example for WIC, we've had clients that come in and, it's part of the WIC program. We have to weigh and measure. So we do have BMI that comes up. We show growth charts to the caregivers. We just let them know where they're at. However, we will actually ask permission. Is it okay that we talk about this today? Or how are you feeling about the growth of your child? Do you have any concerns? And a lot of times they'll say, no, we're good. And we always say, this is where we'd like to see it on the growth chart. However, if they're not ready to talk about it, then we don't go there. We will just talk about what they are ready for. We meet them where they're at. And when they are ready to learn or engage, then we just make it as fun as possible. And what are those fun ways that they can make those changes? So then we facilitate goals around what they can do and not what they can't do. So that way it's not feeling like, oh gosh, well, I can't have this or I can't do that. We are known as the food police. And so dietitians get that bad rap, all foods fit. And again, it's not telling them to do a certain diet or even a diet at all. It's really talking about how can you make some little choices that will be a big impact. So we work with them on that. And before going to the next slide, I just wanted to share the American Diabetes Association actually came out with, it's called the Preferred Language for Weight Inclusive Conversations with Youth and Their Families. So I was just going to provide a couple examples for you guys. So instead of saying, your child needs to lose 5 pounds by the next visit, or have you tried sneaking in vegetables into the meals? That's always a common one too. So instead you can say, well, how can we support so-and-so, whatever that child's name is, in increasing movement or activity? Or what have you tried before? How can we support your efforts and what are you willing to try? What might be some barriers that could make it challenging to make changes as a family? We always make sure that the caregiver is included. And what supports and resources do you already have that can help you be successful? So using and asking some of those questions and using some different language and reframing it. So more like questions instead of statements, possibly. One more example would be, you just need to eat more fruits and vegetables. eat smaller portions, and exercise however many minutes a day you're going to tell them. So instead of saying that, how about one change that has been beneficial for some of our other children or youth that we talk to is to increase a variety of foods. What's a new food you guys would like to try? Or what do you think so-and-so would like to try? What steps can we take to increase a variety of foods as a family? And then maybe you're talking, specifically to the teen or the child, and you're saying, what are your thoughts about food or movement? Let them be involved in that conversation too. It's not always the caregivers, I mean, depending on the age of the child, but providing those ideas and suggestions, with permission, and then they can come up with what works best for them. Okay, next slide. So on this one, I just wanted to show what we have. This is just our brochure that we pass out for our play program, which is actually in the middle of being revamped, but we want to make sure that words matter. We don't call this a weight loss program. We don't call it, and again, we don't really want our children to necessarily lose weight. We just want them to grow at a healthy rate. But we want to make sure that they know it's empowering children and families to foster that healthy eating and active lifestyles. And our mission is really to improve their physical health and also their mental health, because we know that those are related. And then decrease risk factors for chronic diseases, and then improve eating habits. So we just want to make sure that we don't look at that program as a weight loss program. It's for everybody to just learn better habits and to do it as a family. Okay, next slide. And the last thing I wanted to touch on is this is what we did use for our play program while it was in session, but we used the PEDS QL, which is the Pediatric Quality of Life tool. And we received this, we actually modeled this. We found out that St. Luke's was using this with one of their programs. It was called YAY. I don't think that they are using the YAY name anymore, but they were using it. So we actually went on to this website. We contacted the licensor, James Varney, and we did receive permission to use the surveys that they have. The surveys measure physical, social, emotional, and school functioning questions. So there's about 23 questions. Now, in a clinical setting, that might be a little more difficult. I know that it's a hard to just get everything in at a visit, but this for our program that we were using for the play program was really helpful. Now, we launched our play program right before COVID. So as you can imagine, we really don't have enough data that I can actually present here today on that, unfortunately. But I stand behind this tool, and I think it's a really good tool to use. There's a parent perception on their child's quality of life. So that's a separate survey. And then the other survey is the child's self-perception. So they are given separately, and we were providing it at the beginning of the program and then also at the end. And so that way it could help evaluate the program and what's missing or needs to be improved, and also can measure change over time with the clinical changes to health, not only to their mental health, but some of those pieces may fall together, which then can improve clinical outcomes. So as you see here, it is a reliable tool. It's a valid tool. It's flexible, so it can be used in a clinical, community, or school setting. I say brief because at the program side, it's brief to be able to provide that. It might not be it's flexible to be used in the clinical setting, but it might not be as brief there. It does take a little bit longer to do with the kiddos, because they, especially depending on the age, if you've got a 5-year-old and you're working with them and you're providing that survey to them and you're using different ways to get their answers out of them, it can take a little bit longer, especially with their attention span. So that was our experience with it. Next slide. So really, overall, in our programs, the goal is to improve the health of our youth while teaching them to love their bodies at the same time. I know obviously that's really what we want them to do. It's not really about the outside. It's about what's inside of their health and what's going on inside. So with that, that is the end of my presentation. And thank you.
Sorry. Thank you so much, Kim. That was fantastic. I know it's a very, such an important thing to have the right tools to be able to talk to children about health and in particular, body size and avoiding that kind of shame that can go along with living in a larger body. Next up, we have Megan Rasmussen. Megan is a registered dietitian, a nutritionist, and certified health coach with her Master's of Science degree from Loma Linda University. She just celebrated her 2-year anniversary of working at Kootenai Health. She serves as employee wellness coordinator, where one of her main responsibilities is running one-on-one nutrition coaching with employees of the hospital. She also runs a group program for employees that explores how to lose weight without losing your love for food, and focuses on creating a healthy relationship with food and using habit building to create sustainable, healthy lifestyle. When Megan is not working, you can often find her running with her 2 Australian cattle dogs. She just completed her 2nd full marathon last month and is very proud to say she finished in under 4 hours, which is extremely impressive. Welcome, Megan. I will turn it over to you.
Oh, I think you need to unmute, Megan.
I was trying to figure out how to do
There
it.
you go.
Thank you. Thank you, Dr. Peterson. Yes, my name is Megan. I'm a registered dietitian. I am very excited to be here. I was immediately intrigued and excited when Dr. Peterson asked me to present on this topic because it is so close to me personally. So life as a young girl was difficult because the idea that being skinny meant that you were better or prettier or healthier was so prevalent. I remember constantly comparing myself to my friends who were skinnier than me and wishing that I could be like them. And it was actually my struggles with weight and body image that actually inspired me to become a registered dietitian. So today, through my work as a dietitian and a health coach, my mission is to guide people to reach their health goals, number one, without losing their love for food. But a big part of this also includes helping them improve their relationship with food and their bodies, and shifting the mindset from focusing on weight to focusing on health. So when this topic was brought to me, so many thoughts came to my head. I could probably talk about this for hours, but in order to give you guys the most out of this 10 or 15 minutes, I decided that I would address this topic from my perspective, specifically as a health coach. Because as a health coach and a dietitian, I coach people every single day who want to lose weight. But as we all probably know, the topic of weight loss is very delicate. And so I've learned a lot along the way about how to influence change with these clients of mine without making a person feel guilty or shameful about their weight or their size along the way. So I'm going to touch on 2 things today. Number one, why are weight and BMI not the most ideal or accurate indicators of someone's health? And what other health markers should we be looking at instead? And then number 2, how can providers better address patients and help them, those patients who are overweight, without causing shame or guilt? So let's tackle number 1 first. Why are weight and BMI alone not ideal for measuring somebody's health, and what markers should we emphasize instead? So when coaching clients, I always tell them that there's so much more to the story than just weight and BMI. So you are placed into a BMI category based on your weight and your height. And these categories, as you can see here, are underweight, normal weight, overweight, and obese. However, according to the CDC, BMI does not diagnose the body fatness or health of an individual. To determine if the BMI is a health risk, a healthcare provider performs further assessments. And it goes on to say that such assessments can include skin fold thickness measurements, evaluations of diet, physical activity, and family history. And that's exactly what I do during my coaching sessions. Yes, I will look at the BMI, but then I like to assess other measurements and ask further questions to get a bigger picture of a client's overall health. So, what other things do I assess after looking at the weight and BMI? I personally like to look at circumference measurements, body composition, lab results, physical fitness, and even just how a person feels. To me, it's a no-brainer to dig deeper into some of these other health indicators because BMI gives you a very small amount of information. And something that I like to tell my clients when I'm explaining this to them is that BMI doesn't tell you what your weight is actually made up of. And so that's why I like to offer body composition tests to all of my clients, because body composition testing tells you more information on what your body weight is actually made up of. So let's dive into body composition a little bit more here. So body composition is just what it sounds like. It looks at what your body is composed of. And the machine that I use in my office tracks all of these health indicators on the screen here. So body fat percentage, fat mass, fat-free mass, muscle mass, total body water, bone mass, basal metabolic rate, metabolic age, and visceral fat. Now, I'm not going to read all the definitions to you because we would be here for too long and you guys can read what's on the screen. But I just want to highlight 3 of the most important ones to me to look out for as a coach and a dietitian. So number 1, we have body fat percentage. This is the proportion or the percentage of your total body weight that's made out of fat tissue. The next one I like to look at is muscle mass or lean mass. And this is the weight of everything in your body except for fat and bone. And then lastly, I like to highlight the visceral fat. And the visceral fat is a rating of the fat tissue that's distributed deep around your internal organs. And so it's important that we have some fat there, but it's easy to get too much, and we don't want to have too much fat there because that's when we can increase our risk for heart disease, diabetes, and other health issues. And although I'm just highlighting these 3 for you guys today, all of these things are things that I can look at with a client to assess where they are with their health. Now, I know what you're thinking. Wow, that's a lot of metrics. Yeah, it is. It tells you way more about a person than just their weight. And so that's why I really love using this test. Now, I wanted to show you an example of actual body composition test results. And these pictures are actually my personal body composition test results from earlier this year, taken about 1 month apart. Now, in a coaching session, if these were my clients' results, most of them would take an initial look at this and the weight alone, and they would say, "Oh, awesome, I lost 5 pounds, I'm happy with this." And the reason that most people would say something like this is that we are all conditioned to view weight loss, regardless of the circumstances, as a good thing. But if we dig deeper into these results, we will actually see that this weight loss actually wasn't a great thing for me. So if we look specifically at the fat mass here, and the difference between those, it actually shows that I gained 0.6 pounds of body fat. And if we look at the lean mass or the muscle mass, it shows that I actually lost 5.4 pounds of muscle. Okay, so the main reason why I lost this 5 pounds was because I lost muscle mass. And generally, losing muscle mass is not considered a super great thing. Muscle tissue is more metabolically active than fat tissue, and having enough muscle mass is also just important to maintain our physical health. But all of this to say, losing weight is put on this pedestal, right, by so many of us, when in reality, sometimes losing weight is not a good thing. And body composition is going to help us dig deeper and figure out if it was beneficial weight loss or not. Because imagine if you had just stepped onto a regular scale and saw this change here, you would say, cool, I lost 5 pounds, woohoo, I'm meeting my goals, right? When in reality, there was more to the story. So that's why I love using body composition. Okay, so now that we have covered why weight and BMI are not ideal alone for measuring someone's health, let's say that you as a provider have assessed multiple different factors and still feel like weight loss would be beneficial for a patient. What do you do? How do you go about helping someone lose weight without causing them to feel shame or guilt? I could probably talk about this on and give lots of ideas, but I narrowed this down to my top 3 tips for how to do this. So my first tip, let's go into it. Track a patient's progress with more than just weight. Remember, like we just said, we can assess somebody's health with so many more things than just how many pounds they weigh. So make sure you do that. If you can, track their body composition, lab results, physical fitness, etc. And also make sure you tell the person that you are tracking these other things and why. A lot of people get stuck on the idea that their weight is the end all be all of their health. So make sure you're also emphasizing to them that their health is so much more than just their weight. Secondly, connect with your patient or client human to human. Something that really hit me from my health coaching textbook was this quote: "We are them." There are times when we have all decided to change a health behavior, but struggled with actually changing it. Just because we're healthcare providers, just because I'm a dietitian, doesn't mean that we always make the healthiest choices either. And we're not on this pedestal above our patients. So the first thing to remember is to treat that person like a human. When someone tells me that they struggle with stress eating, I don't look down on them and say, well, you've really got to work on this stress eating if you want to lose weight. No, I'm going to say something like, hey, I totally understand. I've struggled with stress eating too, and it's totally normal to feel like stress eating after a hard day. When you relate to them in this way, they feel like you've heard and understood them, and that's going to create trust. They're going to be more willing to work with you and seek out your advice if they feel like they have been understood. So that's tip number 2. And my third tip is resist the urge to write or fix someone. As a healthcare provider, you have a lot of knowledge and tools, and you might be really excited and feel like you can help someone, you have the answer. For example, the patient might tell you something like I drink 4 sodas a day, something that you would identify as an unhealthy behavior. And then you become like Donkey from Shrek, and you're all like, ooh, pick me, I know the answer. Just drink less soda. And I can call you out on this because I used to do this too before I took my health coaching certification. But when we start giving out suggestions or telling someone what to do before we've actually gotten any context about why it's hard for them to change, this can actually make them more resistant to changing. Think about it. What would you do in this scenario if I just nonchalantly said, oh, easy, just drink less soda? You'd probably say, no, actually, it's not easy because of X, Y, Z. And now that I think about it, I'm not really worried about my soda intake, and I'm not coming back to see you. Something else that I learned from my health coaching textbook is, as humans, when someone tells us what to do, it's a natural tendency to want to do the exact opposite. So instead of just trying to fix the person as quickly as possible and throw out suggestions, take the time to listen and then work with them together to create some solutions. And by the way, Never tell someone you need to lose weight, even if you feel like it would benefit their health, because what are they going to do? They're going to walk out of your office feeling defiant and like, I don't need to lose weight, whatever. And they're probably not going to change anything. So I encourage you to relate to your patients, support them, guide them, and let them come to the conclusion of, hey, I want to lose weight. And because this person supported me and they understood me, I'm going to go to them and ask them, hey, how can I do this in a healthy way? So, to quickly recap, BMI does not tell us the whole story of someone's health. Take the emphasis off of weight alone by tracking different health indicators such as body composition, circumference measurements, and lab results. Remember that we are them. Just because we're healthcare professionals doesn't mean that we've never struggled with similar things. Think back to a time when you struggled to change a health behavior in the past and use that empathy to relate to your patients. And lastly, resist the urge to fix someone. Fully listen and hear your patients out, and then work with them to come up with solutions together. And that is all I have for you today. Thank you so much.
Wow, that was incredible, Megan. Thank you. I want to go take your class now. That was fantastic. So we only have a couple of minutes. It looks like we have a hand raised. Would you like to ask a question? Go ahead and unmute yourself and ask a question if you like.
May have been an emoji.
Oh, an emoji. Okay, sorry, never mind. So we only have a couple of minutes, but if anybody has any questions, please feel free to email or chat in. I can direct your questions to the appropriate panelist. And I'm really happy with how this turned out. This was a great comprehensive kind of coverage. You'll get an email at the end of the presentation with information about getting your continuing education credit if you'd like it. And then I just want to give a plug for next month. We are going to be having our book club. And I'm hoping maybe a couple of the panelists can come back and talk to us a little bit next month as well. I haven't asked them yet, but I'm hoping for it. But we have Fat Talk, Parenting in the Age of Diet Culture by Virginia Soul-Smith. This is a very new book. And it's a journalist who exposes the daily onslaught of fat phobia and body shaming that kids face from schools, sports, doctors, diet culture, and parents themselves, and offers strategies for how families can change the conversation around weight, health, and self-worth. It's a really fascinating book, and I think it's going to stimulate quite a bit of discussion. So I encourage you to look into the book at the library. I don't know if we have it available here.
I don't think we have it here yet. It's pretty new.
Yeah, it came out within the last couple months.
It's on Amazon. It's, I think, paperback, relatively inexpensive.
Or Audible.
Share with each other for sure.
Yep. I have a copy if you'd like one, please.
There you go. I would even, so I've started listening to it as well, and I'm a parent and I have school-age children as well, but I find this interesting from the perspective of even not as a parent. So I know the topic says parenting in the age of diet culture, but it is just an interesting look at weight and diet culture and society generally. You don't have to be a parent to find value in reading this book. I also, with Dr. Peterson, want to say a big thank you to our panelists. Dr. Proper, I really loved what you shared. There are real medical reasons why it is important to be aware of your body composition and the risks associated with that. And you do it in such a compassionate way. And there was a comment about somebody who said that taking the time to teach and the reasons why this is, as opposed to saying you just need to lose weight, is so important. And then to Kimberly and to Megan as well, the tools and the techniques that you shared about coaching and how to talk with people, either kids or with employees here at the hospital about weight and weight loss and just how you live in your body, I think is so important as well. And you guys also do that with such inclusivity and compassion. So again, thank you. I think we're both just super pleased with the panelists and with our inclusive care series this month. So
Yeah.
more to come next month with our book club.
Thank you so much, everybody.